Kovatis from ChristianaCare, giving us a talk about evaluating pulmonary ventilations in the neonatal patient population. But before I introduce our speaker, let me go some housekeeping issues. We continue extending CME credits for our tech talks and our ID series presentations. We will distribute the information via email to those who registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Deborah Rees, and she will post her email address in the chat. Some upcoming events I want to mention. Our next Tech Talks, so the Tech Talks are on Thursdays at noon, will be our own Zhu Guizheng from ChristianaCare, from iReach. We'll talk about missing data in healthcare research. So that's a very important topic. You really do not want to miss that one. And our next ID series, which will be on February 24th, and it is a Tuesday, we'll have also another neonatologist, Dr. Ursula Gillen, who will talk about decision-making at periviable gestations. So very interesting topics, both of these presentations. So please make sure that they are on your calendar. So again, I'm really excited to introduce Dr. Kelley Kovatis. Dr. Kovatis is currently the director of the Center for Neonatal Evidence-Based Outcomes and Population Health at ChristianaCare, and also assistant professor of pediatrics in the Department of Pediatrics at the Sidney Kimmel Medical College at Thomas Jefferson University. She obtained her MD from Temple University School of Medicine and did her pediatric residency at University of Virginia Medical Center in Charlottesville, as well as a pediatric fellowship in neonatal perinatal medicine at CHOP in Philly. She obtained multiple awards, the last one in 2024, which was the John Stefano Award for Excellence in Teaching and Clinical Care by a neonatologist. So congratulations, Kelley. As evidenced by her award, she's a teacher, has mentored multiple neonatology fellows for research and quality improvements projects, as well as pediatric residents. She has a really long list of peer publications and also multiple national and regional abstracts and posters presentation, and has also received several foundation-funded grants for her research. But I really want to know is, Kelley, are you now an elite Hyrox athlete? Anyway, we are so delighted to have you and look forward to your presentation.
Thank you so much for that introduction, and thank you all for the opportunity to speak with you today. I'm going to go ahead and share my slides. There's one part in the middle where I'm going to share a link, so it may be a little bit clunky, and I apologize if that looks a little clunky when we get to there, but you'll just have to bear with me. Okay. Let me go to the slideshow, one sec. Okay, everyone can see my slides okay?
Looks good, Kelley.
Great. Okay, so again, my name is Kelley Kovatis. I am a neonatologist at ChristianaCare in Newark, Delaware. My mentor and collaborator is Dr. Tom Schaefer, who is affiliated with Nemours Children's Hospital in Wilmington, Delaware. And the title of my talk is Working Smarter with PneuRip, using accessible, real-time, and objective work of breathing measurements at the bedside to improve the clinical care of premature infants. I have no relevant financial or non-financial relationships to disclose. In this presentation, I'm going to review the benefits and limitations of respiratory inductive splethomography, or RIP, introduce PneuRip, a software application that allows RIP to be used at the bedside, and then demonstrate how our group is using PneuRip in the neonatal patient population. As a little bit of background, respiratory illness is the most common pediatric disease. It is the increasing cause of mortality in children under the age of 5, and children in this age group average 3 to 6 episodes of respiratory infections per year. Pulmonary function testing provides non-invasive measurements of lung mechanics, including lung capacity, rates of flow, and gas exchange. The top figure on the right of this slide is likely familiar to many of us who have looked at respiratory mechanics. It's been on every single board I've taken, but this refers to the normal respiratory cycle. So total lung capacity is the volume in the lungs at maximal inflation. Tidal volume is the volume that moves in and out of lungs during quiet breathing. And then the functional residual capacity, or the FRC, which you see kind of below that red sinusoidal wave, is the volume in the lungs at the end of expiration. It is the point in which the outward elastic recoil is balanced by the inward elastic recoil of the lungs. Vital capacity is the volume of the lungs after the deepest inhalation, and the residual volume is the volume of the air remaining in the lungs after maximal exhalation. Pulmonary function testing is a vital tool in the diagnosis and management of pulmonary respiratory disease. It is often used to diagnose and monitor chronic pulmonary conditions such as asthma, cystic fibrosis, and for me in particular as a neonatologist, bronchopulmonary dysplasia. Unfortunately, pulmonary function testing often requires a cooperative and motivated patient, as you can see in this bottom figure. And so its use in neonatology is somewhat limited because, as you imagine, the babies don't always cooperate with us. So respiratory inductive splethomography, or RIP, as I introduced earlier, is made an optional tool that may be able to be used to objectively measure work of breathing in non-cooperative patients. What RIP does is that it measures thoracoabdominal motion by using to objectively measure work of breathing. So soft bands with sinusoidal wires are placed around the baby's chest and abdomen. In this picture, you can see it as those blue bands around the belly and the chest. And these measurements are obtained using the relative timing and amplitude of the rib cage and the abdominal excursion or stretch of the wires. So we're going to go over this concept in a little bit, but this is what it looks like with these bands around the chest and the belly. So the respiratory system is a system that measures thoracoabdominal motion movements. It has been used clinically for decades. The bands within these systems contain, again, flexible sinusoidal wires that make the measurements. The signals from around the bands go around the rib cage and the abdomen and is generated by stretch as the baby breathes or as the individual being tested breathes. And this is then converted into a mathematical sine wave. So when you and I breathe, if you think about how you're breathing right now, your diaphragm drops, which creates a negative intrathoracic pressure, forcing air to go in, and that is what we do for inspiration. In normal, comfortable breathing, the outward abdominal motion that occurs when our diaphragm moves down is closely followed in time by outward rib cage motion. Exhalation is passive as the lungs recoil and decrease in volume in the inward elastic recoil of the lungs at FRC. So again, as you sit there, notice how you're breathing. Your abdomen and your rib cage move out with inspiration and in with expiration. So the respiratory system measures how well the movement of your chest and your belly correlate and how well they move together. Phase angle is the measurement of the shift between the abdomen and rib cage in their excursions or their movements. So when you breathe comfortably, which presumably all of us are breathing comfortably, our chest and our belly move together. And this is correlated with that top line of the figure on the right, in which the peaks of both the rib cage and the abdomen are in sync. They're in perfect sync, which correlates with a phase angle of 0. When we're in a lot of respiratory distress, you can see this seesaw kind of paradoxal breathing pattern in which your rib cage and your abdomen are completely out of sync. And that is represented by the bottom figure, in which you have a phase angle of 180. And then any variation in between, represented by that middle line, and the right figure would represent a scale of workup breathing. So the benefit of using this system is that we are able to objectively measure workup breathing. So we as humans are able to say, oh, that person or that baby for my patient population is breathing very comfortably, or that baby is in a lot of distress. And so we're very good as human beings on the extreme, but it's that kind of middle range that can be a little bit tricky for us as clinicians, because one person may say that baby is really bad, or maybe a scale of 7 out of 10, but another person may say, oh, that's 4 out of 10. So there's some variability in that middle range. So there's benefit to being able to objectively quantify workup breathing, but this respiratory system has some limitations. It's large. It's on a cart that has to be rolled into the room. And if you can imagine, in a NICU, everything is kind of small. And so we have limited space. In this system, the pattern of breathing, you can only see a few parameters at the time of the test, limiting its ability to make kind of changes at the bedside in real time. Making the measurements required a lot of post hoc analysis, which was very time consuming and often imprecise. And then because it didn't provide instantaneous data and graphics, it wasn't able to be used in a clinical setting. That's where PneuRip has kind of allowed us as researchers to transition the concept of respiratrace from a research tool to a clinical diagnostic tool. So PneuRip is a palm-sized hardware module that associated with an iPad software that addresses many of the limitations of the respiratrace system. It has allowed us to transition from the respiratrace system as a research tool into the clinical setting. So in PneuRip, those bands that I showed you earlier, those blue bands, send a sine wave digital signal through a small polarized wire to the digital signal processor. After that, the processor then sends the data on the breathing patterns wirelessly to the iPad. And then with this new software, we're able to instantly display workup breathing measurements. This data can then securely be sent via email or into the medical record. So this is represent a screenshot of the PneuRip software. So the display on the left represents the view that is seen in real time. You see the sinusoidal wave pattern that's produced from the stretch of the bands around the abdomen and rib cage in that top figure. So the x-axis represents the function of time. That orange line represents the abdominal excursion. The blue line represents the rib cage excursion. We also can see respiratory phase, our respiratory rate, the rib cage contribution, and labor breathing index, or LBI, which you see at the bottom. And that is another measure of workup breathing. It's just a measure of volume rather than phase shifts in the belly and the rib cage movements. And what I hope you can appreciate with this top figure, that you can see that the sinusoidal peaks of the rib cage and the abdomen are lining up. And so that is a very comfortable breathing pattern. The belly and the chest are moving very, very much together, which is associated with a phase angle closer to 0, and in this case, 5. So that is a very comfortable breathing pattern. The display on the right is a summary display that's produced immediately after the study, and we can also download the raw data that can be sent from the iPad into an Excel spreadsheet, and then we can use any statistical software of our choice to analyze the data. So as I hope to have shown you, the benefit of PneuRip is that it's portable and sized for bedside and clinical use. It's user-friendly. If I can figure it out, anyone can. And then you can have real-time data that can then be compatible with the EMR. So it has a lot of potential for use. NeuRip has been used in the clinical setting. This is not new. So there was a study by Strang et al. That demonstrated differences in phase angle, labor breathing index, and heart rate for 22 children with neuromuscular disease and compared this to a healthy control. NeuRip was used in a rodent model to measure workup breathing. One of Dr. Schaefer's PhD students used NeuRip for children with Duchenne muscular dystrophy to measure workup breathing. And then there was another study that looked NeuRip to look at children with McCoy, a mucopolysaccharide storage disease, to make measurements in that. So it has been used clinically, but it has not been frequently used in the preterm or neonatal patient population. And babies, or especially preterm infants, are at increased risk of asynchronous breathing. So the use of NeuRip in this population has the potential to answer a multitude of clinical questions and hopefully improve outcomes, which is what we're always trying to do. So if you recall from our earlier slides, FRC is the point in which the outward elastic recoil is balanced by the inward elastic recoil of the lungs. Again, in normal, comfortable breathing, the outward abdominal motion that occurs when the diaphragm moves down is closely followed in time by outward rib cage motion. So because of the physiologic differences between adults and infants, such as more compliant chest wall, poor lung compliance, smaller airways and increased resistance, and muscles that are more susceptible to fatigue, the use of NeuRip may be able to provide us with some guidance as far as how babies are breathing and how our interventions may change their breathing patterns. So asynchrony can lead to diaphragmatic muscle failure and increased energy expenditure. So Keynes et al. In a study done in 1978 looked at the muscles of premature infants and showed how their muscle type changed. So she obtains specimens from the diaphragm and intercostal muscles of infants and adults and classified them in two ways. One was type 1 fibers, which were slow twitch fibers resistant to fatigue, and type 2 muscle fibers, which are fast twitch muscles, which are more easily fatigued. And this study demonstrated that type 1 fibers increased over time, and type 2 fibers decreased over time with increasing age. So premature infants had less type 1 fibers compared to full-term infants, and therefore were at more increased risk of fatigue. This is demonstrated by this figure here, in which the x-axis represents age and the y-axis represents percentage of muscle. And as you can see from this figure, the amount of slow twitch muscles increases over time, and the amount of type 2 fibers or fast twitch muscles decrease. Because of this and the points discussed in our previous slides, infants are more likely to demonstrate asynchronous breathing and increased workup breathing. So now this is where I'm going to get a little bit clunky, so bear with me. I'm going to try to show you just a representation of what workup breathing looks like. I knew that was going to go poorly. I apologize. Let me try that again. Can everyone hear me okay?
Yes.
Okay, so sorry about that. I was worried about it and I fulfilled my prophecy. Okay, so can you guys see a YouTube video now?
Yes.
Okay, so I'm going to make this bigger and then show you the video. So in this video, you can see workup breathing in a neonate. So as you can see with the arrows pointing on the right, that baby is showing asynchronous breathing in which the chest and the belly are not in sync. On the left, that baby is more comfortable and you don't see as much asynchrony. So that's just a physical representation. Okay, so now I'm going to try this again. Hopefully I don't cut out. Stop sharing. Share. I'll go back to my PowerPoint. All right, that was executed much more smoothly than the last time. And can everyone now see my slides again?
Yes.
Okay, great.
Yes.
All right, thank you, everybody. So the thought process that we had as a group was, can we use PneuRip to explain clinical observations and improve outcomes in preterm infants? But in order to do that, we first have to establish normative work of breathing indices and oxygen saturations in preterm infants. So you can't make changes if you don't know what the baseline is. Now, some people have looked at this. So this study was published in 2019. It was a review paper that included a large range of pediatric population looking at phase angle and work of breathing in this group. It didn't contain very many patients, and the youngest patient, which I think you should note, is around 6 months of age. So that was the youngest that this patient, that this review included. And what you can see is that there was a significant amount of variability in phase angle early in life. This is demonstrated on the figure on the right. You can see there's a wide confidence interval for the phase angle represented by the y-axis before the age of 3. And then after 3, the confidence intervals decrease and kind of stabilize. So 1, there's a lot of variability the younger you are. And 2, we noticed that there was not a lot of data on phase angles or normative phase angles in babies who were under 6 months of age. So this led us to one question that we started looking at was, what is the difference between the phase angle or work of breathing parameters for a baby who's born at term versus a baby who's preterm? This study was conducted by my mentee, Dr. ChristianaCare, who was one of our former neonatal fellows, who looked at work of breathing indices in term infants compared to a cohort of healthy preterm infants at discharge. This study included 32 preterm infants born prior to 32 weeks and 31 term infants. PneuRip studies were performed at discharge. And our initial hypothesis was that work of breathing would be increased in premature infants compared to term infants. So this table represents just the demographic information and then some of the study outcomes. And not surprising, preterm infants were born at an early gestational age. That was by design. And they were older at the time of the study. So most premature infants, depending on their gestational age, can spend a month, 2 months, 3 months in the NICU, whereas a term baby will typically spend 2 to 3 days in the hospital. So the chronological age of these patient populations is significantly different. Additionally, when you look at the corrected gestational age, so when you look at where they are, term babies are 1 day old and they're like, right around their due date, 39 weeks, whereas preterm infants are usually ready to go home before their due date, but are still younger than those term population. And what we interestingly found that the respiratory rate for preterm infants was increased compared to term infants. That didn't surprise us. The saturation rates were, saturation levels represented by the SpO2 were higher in preterm infants than term infants. That surprised me initially, but then when I start thinking about the physiologic changes that occur when you are a fetus to when you become a baby living outside your mom, that wasn't as surprising. And when you look at the numbers, it's probably, although statistically different, not clinically significant. And then the heart rate was a little bit lower in preterm infants. Again, probably based on physiologic changes that occur during the first few days of life. What really surprised me, went against my initial hypothesis, was that the phase angle for preterm infants was significantly lower in preterm infants compared to term infants. So the phase angle in the preterm infants at discharge was 49 around, and the preterm infants was 73 with a p-value of 0.017. And then even when we adjusted for sex, race, and ethnicity, prematurity was strongly associated with decreased breathing asynchrony or less work of breathing than with term infants. So this was surprising. So this was not what we had thought was going to happen. And so then we had to kind of think about why that was. And so, as Claudine mentioned, I am a former college athlete, and I now train in this high rocks racing. And so this got me thinking about maybe we're seeing something with muscle conditioning. And so I started looking at the literature, and they're actually the answer and maybe the explanation for what we're seeing in this discrepancy from what I expected to what I observed may kind of go back to the diaphragm. So the diaphragm, as we've already talked about, is the major inspiratory muscle in neonates. And we know that diaphragm thickness is positively correlated with age. So Raymond et al. Demonstrated that diaphragm thickness increases with postmenstrual age. This is shown in the top figure on the right, in which the x-axis is postmenstrual age and the y-axis is diaphragm thickness. And as you can see, there's a positive linear correlation. As you go through postmenstrual age, the diaphragm thickens. Additionally, he demonstrated that diaphragm excursion decreased with increasing age. This is represented by the bottom figure on the right. This suggests that the diaphragm becomes more efficient with time. Now, the etiology of this change is unknown. This was like a patient population in which he followed them as they went through the gestational ages. And so is this change that you're seeing where the thickness increases and the efficiency increases, is it due to diaphragm conditioning with respirations after birth? So when you're practice breathing in your mom, you are not actually breathing against gravity, you're not breathing against any resistance, your lungs are fluid filled, or is this a thickening of the diaphragm that would naturally occur with time? And so it's unclear about what the relationship is. And so there's been some studies that may address this and may kind of look at this, but we're still not 100% sure. But I found this study that was published in 2023 by Yang et al. And what he looked at was, this study looked at infants with BPD, which we'll go over again a little bit later, but BPD is a chronic lung disease condition in premature infants in which they have increased work of breathing, versus a healthy control. So the healthy control for this patients were term infants. And unlike what we had done in our study with Dr. Jha, they were matched at the time of the study, they were matched by their corrected gestational age. So they were the same corrected gestational age, but chronologically they were very different. So the BPD group had a gestational age of 26.3 at birth, whereas the healthy control was 37.9. So the number of days in which they existed on Earth was much different, but their corrected gestational ages were similar. And so what they showed was that infants in the BPD group had diaphragm thickness that was significantly lower than the healthy control with a p-value of 0.01. Now this is on the third row. This sort of kind of looks into the question in that they're the same gestational age. So does this baby have thinner diaphragm, and that's related to the disease? BPD babies are often intubated for a long time, and there's been studies to show that when you're intubated, because your diaphragm doesn't have to work as hard because the machine is working or breathing for the baby, that there is an associated loss of thickness. And so just like when you're working out or using your muscles, if you don't use them, you lose them. So the diaphragm thins. And so you may see this thinness that we're seeing may be related to lack of use or decreased use because they were intubated. But then when they looked at the functionality of the diaphragm, which is represented further down in the graph, they looked at thickness fraction and exertion, and both were higher in the BPD group. So this is again represented by the last two rows of this table. The thickness fraction is an indicator for improved diaphragmatic function. The excursion is a measure of motion, and increased motion suggests compensation. So although the infants with BPD at the same corrected gestational age had thinner diaphragms, so muscles that were smaller, they had more efficient muscles. And so maybe that kind of leads into why we saw the difference with our perm versus preterm comparison. So this led us to, then we wanted to kind of look at what is workup breathing for babies with BPD versus workup breathing with babies, preterm infants who did not have BPD. So this was a study that I conducted looking at preterm infants, all born before less than 32 weeks. But some babies had prematurity, and some babies had BPD, a diagnosis of BPD, and some babies didn't. Again, BPD is a measure of disease in which they have a lung disease. Their lungs are sick. Not surprising, the babies who had BPD were slightly younger at birth, but they also were a little bit older at corrected gestational age at the time of the study, because this study was, again, done at discharge when they were all getting ready to go home. So chronologically, the babies with BPD were a little bit older, statistically with a p-value of less than 0.001, than the babies without BPD. But proportionally, the number of days lived of their whole life, there was less of a difference, obviously, in a 1-day versus 30-day-old baby, versus 73 days versus 35 days. So maybe that accounts for some difference. And what we found here is not surprising. The oxygen, the SpO2s, or the oxygen levels for babies with BPD, was lower than the babies without BPD, representing more disease in the BPD group. BPD group also had more time with saturations less than 85 and 80% than the babies who did not have BPD, and the heart rates were no different. But the phase angle was different. So there was a statistical difference in the phase angles in the babies with BPD versus no BPD. So no BPD had an average phase angle of 52.6, whereas the average phase angle for the babies with BPD was 73.9 with a p-value of 0.039. So babies with BPD had increased workup breathing. This phase angle was comparable to the phase angle that we saw in the term infants at discharge who were only 1 day old. So we're working on establishing normative data to figure out how do babies breathe, and how is this impacted both by chronological age and gestational age. And there's a lot of variables that we're still trying to figure out. But I did want to share how we're using some of these workup breathing indices to explain clinical observations and interventions. So over the next few slides, I'm going to talk about 3 studies that we've done using PneuRip in our NICU. So the first study was conducted a few years ago by one of our former fellows, Dr. Mara Gable. This was published in the Journal of Neonatal Perinatal Medicine in 2022, and it was entitled The Impact of Kangaroo Care on Workup Breathing and Oxygen Saturation in Very Low Birth Weight Infants with Respiratory Distress. So kangaroo care, just to give you a background, is defined as the prolonged skin-to-skin contact between an infant while lying prone and on a bare chest. Multiple studies have demonstrated long-term benefits of kangaroo care. It reduces mortality, it improves growth and breastfeeding retention, it reduces the perception of pain, and it improves mental developmental index at 24 months and executive function at 5 to 10 years. So kangaroo care is good. Multiple studies have demonstrated that there's increased physiologic stability in preterm infants undergoing kangaroo care. This is a summary slide of some major studies that looked at this, and they had less bradycardia and desaturations, less periodic breathing, higher saturations, and improved cardiorespiratory stability. So what we were looking at is some of these changes that you're seeing, this physiologic stability and this long-term improvement, is it due to improved work of breathing? Is that why you're seeing these kind of short and long-term improvements? And so we set out to show whether kangaroo care impacts work of breathing. So we have our inclusion criteria there. The only thing that we excluded were babies who may have had things that would interfere with our ability to use the band, and also something that would interfere with their ability to do kangaroo care. This is a prospective observational study. This is kind of a description of what we did. Every baby was measured in both the supine position, or it was measured in the supine position, which is on their back, or doing kangaroo care. They were just randomized to receive one first and then the other one, so that we didn't have any potential confounding with how they started versus how they ended. So we randomized that, but both babies, or all babies, were measured in both positions. This is just a consort diagram outlining how we got to our included patient population. And this is a table that is outlining our demographics. So again, these babies were all similar. There was no statistical difference in the group that was randomized to get the standard care first versus the kangaroo care. And so there was, as expected, there was no difference. And, unfortunately, we didn't find any difference in their work of breathing measurements. We did find that babies in the kangaroo care did have slightly higher heart rates with a p-value of 0.05, but not clinically significant. And we found no difference in the mean phase angle. And this had no impact on whether you were randomized to receive standard care first or KMC care first. So this is represented on the figure on the right. So the conclusions that we made from this study is kangaroo care is safe and well tolerated without observed increased work of breathing or with physiologic instability, but the physiologic and long-term benefits of kangaroo care may not be related to changes in work of breathing. The next study we looked at was looking at how work of breathing changes when you adjust high flow, which is a way that we support respiration. I'll go over this in a little bit. In a premature infant. This was published in the Journal of Perinatology in 2021. So I've kind of alluded to BPD, but BPD or chronic lung disease is a common adverse outcome for premature infants born at less than 30 weeks. It affects approximately half of all infants born with a birth weight less than 1,000 grams, and it predisposes survivors to chronic respiratory and cardiovascular impairment, growth failure, and neurodevelopmental delay. The introduction of antenatal steroids, postnatal surfactant, modern respiratory care, and improved nutrition has changed the definitions and characteristics of BPD. Because the patient population that we're dealing with is born so early, oftentimes they do require respiratory support after birth. So I've mentioned this a couple times, but preterm infants are exposed or at increased risk for a failure to transition from in utero life to extrauterine life because they have high chest wall compliance, weak respiratory muscles, incomplete surfactant production, and underexpression of transepithelial sodium channels. So oftentimes these babies who are born prematurely need invasive mechanical ventilation to save their life. It's necessary. It's a necessary evil. But we know that by being intubated or having mechanical ventilation, this increases your risk of BPD because it causes barotrauma, volume trauma. It's not how you and I are supposed to breathe. So it causes damage, which in turn causes inflammation. So we as the neonatal community have tried to try to prevent BPD. And so the use of non-invasive respiratory support is one strategy. So this is, instead of providing a breathing tube, can you give non-invasive respiratory support that supports the baby's breathing but doesn't involve a breathing tube? Can you do that to try to prevent BPD? And there were three major studies, the COIN trial, the support trial, and a study published by Dunn et al. That looked at premature infants from 25 to 29 and 6 weeks and compared them CPAP versus intubation And although there was no difference in the risk of BPD, which is a hard outcome to measure because it requires a lot of patients, it did require less ventilator days. So we as neonatologists are always trying to use non-invasive respiratory support when possible. So the two ways that we oftentimes provide non-invasive respiratory support is through CPAP or high flow nasal cannula. High flow nasal cannula has gained popularity as an alternative to nasal CPAP. So CPAP is a way to provide descending pressure through the nares by a means of a large bore unrestricted nasal prong. It delivers, it's through pressure, it's a closed system, so you know how much pressure you're giving. It maintains FRC, or that functional residual capacity, and it improves oxygenation and VQ mismatch. Cons is that there's a slight increased risk of pneumothorax, gastric distension. It can cause some trauma to the face and nares because it fits very tightly, and there's a perceived lack of comfort. So there was kind of a push to using high flow nasal cannula, which is a nasal cannula that delivers flow, and which in turn delivers pressure, but you're regulating the flow, and is perceived as being more comfortable, allow better patient parent interaction, and it is smaller. But the problem with high flow nasal cannula is the amount of pressure that is delivered depends on the fit of the nasal cannula. So this is just a picture for non-neonatologists or people who haven't been in the NICU. On the left is the CPAP mask, so a little more clunky. On the right is the high flow nasal cannula mask, a little less invasive, works two different ways, and we're trying to use these more than putting a breathing tube in. Now, at the time of this study, the NICU was using high flow nasal cannula a lot. And around this time, there was some mixed evidence as to whether high flow nasal cannula was as effective as CPAP in preterm infants. So there were some studies that showed benefit and that it wasn't any different or even better. There was some studies that showed that it was worse. And so now the use of high flow nasal cannula is not used as frequently for babies less than 28 weeks. With that being said, there is some utility in it, and I'm going to go over that in just a bit. This was a study conducted by one of our former fellows who was there before I was, Beatrice de Jong, who published in the Journal of Perinatology in 2014. And she looked at phase angle or RIP measurements on various levels of support: high flow nasal cannula 3, high flow nasal cannula 5, CPAP of 5, and CPAP of 6. And she made these measurements at each of these in random order, and then we're looking at the representation of the phase angle of each. And the phase angle was significantly higher during the high flow nasal cannula measurements compared to the CPAP measurements, with a p-value of less than 0.01. This figure, the y-axis represents the phase angle, the x-axis represents the intervention, and you can see the phase angle is the highest on the left at high flow nasal cannula and the lowest with the CPAP of 6. So interestingly, babies on CPAP demonstrated more cluster breathing, but the phase angle was lower on the CPAP of 6. So the aim of my study was to look at whether you could measure phase angle at the bedside with real-time shifts in the high flow nasal cannula to see how that changes work of breathing. This is a prospective observational pilot study, and this is kind of representation of what we did. So we made baseline measurements, and if the phase angle was less than 40, we decreased the amount of support by 1 and continued to measure. And then if the phase angle was greater than 40, we increased. Now that number was somewhat arbitrarily selected because at the time we didn't know what normal phase angle was for this patient population, but we were able to demonstrate that there was differences. This is our consort diagram to demonstrate how we got to where the babies that we included. This is just to demonstrate the entire cohort, so all 32 babies, and then the babies included in the final analysis. We did not include some babies who went down on their respiratory support or infants that did not receive as much incremental increase. Just from a statistical reason, it was required to do that to make the statistics make more sense. But you can see there was no difference in the babies that were included in the final analysis versus the entire cohort. So we found in this study that babies who are premature and who are on respiratory support have abnormal phase angles. So their average phase angle was 71 degrees. The babies who were included in the analysis had a higher phase angle, which is not surprising because those are the babies that required increased respiratory support. There was no difference in their respiratory rate, their oxygen levels, or their heart rate. And 62% of the infants demonstrated a greater than 20% improvement in their work of breathing indices from baseline during the stepwise incremental algorithm. So when we did regression modeling, we were able to show that gestational age did in fact impact phase angle. So after adjusting for baseline high flow nasal cannula, infants born at a gestational age of greater than 28 weeks had decreased work of breathing indices compared to infants born at less than 28 weeks. And this kind of goes into what the data has really emerged, in which the younger babies, the babies less than 28 weeks, don't do as well on high flow as the babies who are older than 28 weeks. So this kind of is consistent with that. And then also we saw that the impact of a step change on phase angle was significantly modified for gestational age. So babies at less than 28 weeks with 1 liter per minute increase in flow, they had a decrease in their phase angle by 9.3 degrees. But if they were greater than 28 weeks, 1 liter per minute flow increase in flow was associated with an increase in phase angle by 11.9 degrees. So this is consistent with that babies who are a little bit older probably do better with high flow nasal cannula than the babies that are younger. Additionally, we showed oxygen saturation and stability improves with increasing high flow nasal cannula rates. So the x-axis is the high flow nasal cannula rates. The y-axis is the standard deviation of the oxygen saturation. So that's measuring variability. And as you can see, with increasing flow rates, the variability in the stability or variability, however you want to think about it, goes down as you go up on flow. So with 1 liter increase in high flow was associated with decreased oxygen saturation variability or instability. A 1 liter per flow minute increase in high flow nasal cannula resulted in a 23% decrease in oxygen variability. So there was more stability with higher flow. So what we concluded from this study was that a majority of infants that we're providing high flow that clinically we think are on the right level of support are not. Gestational age impacts work of breathing indices in response to changes in flow. So the babies who are older had a better response to changes in flow than the babies who were younger gestationally. And oxygen stability improves with increasing flow. So the other conclusion that we had is that respiratory demands varies throughout the day. And what we're doing right now by just kind of switching them every 12 hours, every 24 hours, is probably not meeting their clinical needs. The last study I'm going to go over is the effect of positioning on work of breathing and oxygen in preterm infants. This was just published this year in 2025 in neonatology. And so what I've kind of shown you so far is that a lot of variables impact work of breathing. We encourage babies to be positioned on their back. So anyone who's had children, your pediatrician tells you to have them sleep on their back. And this was because prior to 1992, there was an increased risk. There was an observation that babies who were placed on their belly are in the prone position or at increased risk of sudden unexpected infant death. So in 1992, there was that back to sleep push, and then the AAP now recommends that all babies sleep on their back. With that being said, and in clinical observations, we have observed that babies actually seem to do better on their bellies or in the prone position. So although the prone position is not supported by the American Academy of Pediatrics, we as clinicians see that they do better on their bellies. And there's been multiple studies to show that babies on their bellies or in the prone position have improved oxygenation and respiratory mechanics. Wilson et al. Published a paper way back in 1992 looking at phase angle and showed that babies in the prone position had more synchronous breathing. And so how do we handle this kind of difference in what we're recommending to families, but also the physiologic difference? We also have a lot of babies who frequently spend time in their car seats or at an angle in that semi-reclined position with those bouncers that a lot of us had for our kids when they were little. And so we wonder, is the same physiologic differences that you see in the prone versus supine, do you see that in the semi-reclined positions? So other studies have shown that in that semi-reclined position, unlike the prone position, that they have cardiorespiratory instability. This led the AAP to recommend that all premature infants under the age of 37 weeks at birth get a car seat test prior to discharge. Now, this is where it gets a little bit dicey. The Canadian Pediatric Society discontinued this recommendation many years ago because they found that the data lacked evidence to support the practice of routine car seat tests. So they haven't used car seat tests for many years, and they haven't had any adverse outcomes. So there's a little bit of a dichotomy in what is recommended by the AAP versus what is done in Canada. So it seems where there's variation in practice, there's a clinical question. And so there has been some studies by Willett et al. Who looked at workup breathing in the semi-reclined position, but she used pulmonary function tests, which required sedation of the patient. And she found that oxygen saturations were decreased in that position, but the baby had improved lung compliance, decreased resistance, and reduced workup breathing in the semi-reclined position. But it's hard to interpret this from a clinical standpoint because the baby was sedated. And so we then wanted to look at this and how does being in that semi-reclined position impact workup breathing? So this was our aims in our population. This is our consort diagram to how we got to it. And what we ended up comparing was workup breathing measurements in the supine position for about 25 minutes to the car seat test for 90 minutes. And we had this is the demographics for the whole cohort, and then we divided it into BPD versus no BPD, just to kind of see if having that disease process has any impact on your workup breathing in the semi-reclined position. And what we found was that infants demonstrated increased workup breathing in the supine position compared to the semi-reclined position. So this was true for the whole cohort and then also for the no BPD versus the BPD group. So the phase angles were higher in the supine position than in the semi-reclined position. The saturations were a little bit higher in the supine position than the semi-reclined position, but that met statistical but not clinical significance. And this was seen in the no BPD group, but not in the BPD group. There was no difference. And then no difference in heart rate or breaths per minute, or sorry, respiratory rate. So in conclusion, we thought premature infants have improved workup breathing indices in the semi-reclined position compared to the supine position. So I'm not going to go against the AAP, but perhaps the car seat test isn't testing what we think it's testing. Healthier premature infants had statistically but not clinically significant lower saturations in the semi-reclined position, and body position does impact your respiratory mechanics. So in the future, what I'm hoping to look at as some of the questions that have come up during the study was how does workup breathing change over time and at various gestational ages? So there's definitely a lapse in the research as far as is that change that we're seeing with term versus preterm due to chronological age, or is it a change that you would see as the baby grows regardless of chronological age? So we need to do studies looking at phase angle as it changes over time, but also phase angle for a baby who is corrected to 37 weeks compared to a baby who is 37 weeks. I'm very interested in work of breathing indices with lung ultrasound, which I'll go over really quick. I know I'm running out of time. And then I've submitted a patent looking at automated machine learning that will use non-invasive respiratory support systems that are just based on real time. So let me go over that real quick, and then I'll leave a few minutes for questions. So electrical impedance tomography is something I'm very interested in. It's an emerging technology, and it's a non-invasive way to view the images of the lungs to allow clinicians to optimize lung function and ventilation. It has been shown to accurately predict the need for supplementary oxygen at 28 days in preterm infants. So by establishing FRC, you're better able to support the baby. And so I'm interested, and I've reached out to the company that is looking at EIT and neonates. It's not approved for clinical use, but it's approved for research to try to correlate these EIT images with work of breathing to see if you can connect the two. And then I have submitted a patent to develop a non-invasive respiratory support system that automatically adjusts based on machine learning on the baby's respiratory needs. So it's been shown in Europe that automated FiO2 delivery improves outcomes. We oftentimes use volume targeted ventilation, which adjusts based on the baby's compliance, both of which improve outcomes. So I anticipate that if you can develop a non-invasive respiratory support system that adjusts based on the baby's needs throughout the day, rather than relying on a human to adjust it, that we may have better outcomes because the babies are getting better support. So these are my take-home points, which I won't go through just for the sake of time. And at this point, I will open the floor to any questions. These are my acknowledgements of my mentors, Dr. Robert Locke, Tom Schaefer, our research coordinator, Amy Mackley, the fellows that I've mentored, Mara Gable and Kanish Jha, and then obviously Kashab, who is my statistical savior, because he's helped me so much with the statistics. So I'm going to stop sharing my screen and then open up for questions.
Well, thank you so much, Kelley. This is amazing and yeah, really incredible. Any questions?
Let me see if there's any in the chat too.
Question. I mean, I have a couple of questions also that I can. So you showed that the I mean so babies over 28 weeks that what's the word?
High flow nasal cannula.
The high volume cannula was working better than for baby under 28 weeks. So what do you do for very young babies then? And do you base your decision on PneuRip on PneuRip?
Well, not yet. That's my goal, is ultimately to try to use some sort of system in which we're able to measure work of breathing. Because again, I think the benefit of PneuRip is that it's an objective measure rather than relying on human interpretation. Right now, I'm a big proponent that we use more CPAP in that younger patient population. Another research study I've done was looking at extended CPAP, which is increasingly being supported in the literature, that these babies should be on CPAP longer than even you think that they need, just to give that kind of consistent pressure for lung development. So I usually advocate for keeping them on CPAP until 32 weeks corrected or over 1,500 grams. So I only use high flow for the bigger babies.
For the bigger babies, right? And so,
oh, go ahead.
And so, I guess you're still working on establishing the standard for normal PneuRip values. standardizing PneuRip on normal babies. I mean, normal babies, premature babies, but who don't have lung disease. Is this also what you are doing?
Yeah, so I think we have the studies that we've done that establish normative data. We have some information on what these babies look like with BPD versus not. That was one of the studies I presented. And we know that premature babies breathe differently than term babies. And so we don't know, and I try to go over that with the diaphragm changes and the fiber changes, are the changes that you see in the work of breathing, is it because of chronological change? So babies are breathing against resistance, against gravity for longer, and that changes your muscle dynamic, or is it a natural process that would occur regardless? I don't think that has been established, and so that's something I hope to do, is to try to look at how that breathing pattern changes when you have external variables versus like natural. Like if a baby corrected at 37 weeks is the same as a baby who's born at 37 weeks. So we have to do more studies on that. A lot of our intervention studies are matched, so they're the same baby going through an intervention, so a pre-post. So then that allows us to compare them because the baby's the same. But if you really wanted to take this on a larger scale and really establish like whether certain interventions impact the baby on a bigger scale, you'd want to be able to compare it to normative data rather than matched data.
Yeah, that makes total sense. Any other questions? All right.
All right, sorry about the snafu with the YouTube video. It makes me nervous. I buckled under the pressure, but I got on pretty quick. So
no, that was great. No problem. And it was very, I mean, we could see exactly the difference. It was very informative, very, very informative.
All right, well, thank you so much for this opportunity. My email is provided in the slides, so if you have any questions, please don't hesitate to reach out to me directly.
Thank you.
Thank you.